Bismillahirrahmanirrahim. He who finds a path is a pathfinder, even if the trail has to be found again by others, and he who walks far ahead of his contemporaries is a leader, even though centuries pass before he is recognized as such. Assalamu alaikum. My name is Dr. Momena Zia, and I'm a PGR at Community Medicine Department. Today I'm here to critically appraise under Gather checklist under kind supervision of supervisor Professor Dr. Saira Afzal. I'm going to use the Gather checklist, which is guidelines for accurate and transparent health estimates reporting. This is an 18-item checklist, which will see the article is fulfilling or not. So the title of the article is Incidence, Prevalence, and Global Burden of Schizophrenia, Data with Critical Appraisal from the Global Burden of Disease, GBD 2019. This is the abstract of the article, which shows there are no demarcations or headings. So this is an unstructured abstract. Moving on to the introduction. First, I'm going to read the important lines from the introduction, and then we're going to apply the checklist. The Global Burden of Disease 2019, GBD 2019 study provides estimates of the prevalence, incidence, and burden of medical disorders, including mental disorders and schizophrenia. GBD 2019 estimates disease burden, that is, disability adjusted life years, DALYs. One DALY equal to loss of one healthy year of life by summing up the estimated years of life lived with a disability, which is YLDs, non-fatal burden, and the years of life lost, YLLs, burden related with death. Previous publications have reported on the GBD estimates. Like in 2010 GBD data, schizophrenia has a lower prevalence than other mental disorders. It globally accounted for more than 7% of burden associated with mental and substance use disorders, overall and across any group. Subsequently, the GBD 2016, including 129 data sources, reported that globally the raw prevalence of schizophrenia increased from over 13 million people in 1990 to almost 21 million cases in 2016. Furthermore, in 2017, GBD report conducted that from 1990 to 2017, GBD 2017, the global age standardized incidence rates of schizophrenia have increased. More recently, a systematic report of GBD 2019, capstone paper encompassing 396 medical diseases, shows a slight increase in the burden of schizophrenia among people aged 25 to 49 years of age. A subsequent report from GBD 2019 Mental Disorders Collaborators Group, narrowing the focus to 12 mental disorders, showed that schizophrenia ranked fifth as a cause of burden in individuals aged 15 to 24 years, and third after depressive and anxiety disorders, which have higher prevalence among people both sexes, aged 25 to 69 years, and fourth in more than 70 years olds, respectively. This article clearly indicates the indicators and population, including age, sex, and geographic entities, and a time period of 1990 to 2019 was fulfilled. According to moving on to the list of funding sources, this has not been explicitly mentioned in the article, so leaving a gap. So these are the indicators for a quick revision. Prevalence, incidence, and disability adjusted life years. They were discussed in the first paragraph of the introduction, which I've read. So the prevalence is the proportion of population affected by schizophrenia. Incidence is the number of new cases identified annually, and disability adjusted life years is a measure combining the years of life lost due to premature death and years lived with disability due to schizophrenia. So this study has occurred across the time period of 1990 to 2019. So population has been demarcated on the basis of sex, containing both males and females. Age group, all the age groups were included, but but a specific increase has been seen during 20 to 24 years of age. Now the STIs has been included, which are the socio-demographic indices. Uh, Global regions. For 204 countries were included, whereas seven super regions were included: Southeast Asia, High Income North America, and 21 GBD regions. This study has also described the data where it has been taken from, like census, household surveys, registries, and mentions access through the Global Burden of Disease Collaborative Network's website. This study included data only on schizophrenia as defined by DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, and ICD, which is the International Classification of Diseases. Only prevalence, incidence, and disabilities were included, while excluding the mortality data and data sources with insufficient quality. So this data has also, this study has also provided information on all the included data sources and their main characteristics. As mentioned, the institute name population has been properly described. The data collection method is described, and the years of the data collection has been mentioned along with sex and the age range. Diagnostic criteria and the measurement methods are also being described along with the sample, which will be seen in the next paragraphs. So this is from the article. This shows the data source. The highlighted part shows that the data has been collected from census, household surveys, civil registrations, vital statistics, disease registries, health service use databases, air pollution monitors, satellite imaging, and disease notifications, among other sources, in total of 86,249 sources, including 19,354 deaths, 31,499 on incidence, 19,773 on prevalence, and 26,631 on other metrics. So this is the data source. Now the characteristics, they were made depending upon the region, income group, sex, and year from 1990 to 2019, and are presented as raw and age standardized measures. The socio-demographic index accounts for income per capita, educational attainment, and total fertility rate in women less than 25 years of age. Estimates are provided by STI group, which are low, low, middle, middle, and high, middle, and high. So this is the points taken from the article. The reference information has also been provided. So the data was compiled and managed by the Global Burden of Disease Collaborative Network under the Institute for Health Metrics and Evaluation, IHME. So the GBD results tool on the IHME database provides access to the underlying data sets. So population represented, 204 countries and territories grouped into 21 regions and super regions. The sex and age has already been described. The diagnostic criteria, DSM, Diagnostic and Statistical Manual of Mental Disorders. So this point has been followed. The article has also showed the measurement methods as years lived with disability formed the basis for DALY calculation. However, mortality-related years of life lost, YLLs, they were excluded as deaths were attributed to the other causes. Sample size has also been mentioned. So this point has also been followed. Moving on to the data inputs, the article has identified and described any categories of input data that have potential important bias. This has been discussed on page 8, paragraph 2, where the potential bias has been discussed, such as underreporting in low-income countries and differences in data collection quality between regions. The study excludes mortality data directly attributable to schizophrenia, such as deaths due to suicide. Other data inputs, this article has also included other data inputs under the heading of socio-demographic index. And they have been further divided into further categories on the basis of income per capita, educational attainment, and fertility rates in women under 25 years of age. So the further groups are divided as low STI, low middle STI, middle STI, high middle STI, and high STI. Estimates across socio-demographic categories is snipped from the article. So across STI categories, 8 standardized prevalence, incidence, and DALY indices of schizophrenia, they were particularly high in countries with high STI. In 2019, in high STI countries, the 8 standardized prevalence of schizophrenia was 335.95 per 100,000. Without significant increase from 1990, while the prevalence increased by 3.12 in high middle STI countries. No significant age standardized prevalence changes emerged for middle, or low STI countries, while age standardized incidence was the highest in high STI countries. So the data is provided as publicly available at the Institute for Health Metrics and Evaluation. This is the site. So this point has also been fulfilled of the gather checklist. Moving on to the data analysis, the article completely provides a conceptual overview of the data analysis, which has been done by Bayesian matter regression, and DISMOD MR 2.1, which is a statistical model that synthesizes data across regions, time, and population. So have a little overview on Bayesian matter regression. So this is a statistical approach that is used in GBD to combine data from different studies and sources while accounting for variations in data quality and study characteristics. So Bayesian methods provide a way to update the probability based on observed data, which is helpful in synthesizing a wide range of health data from various countries and populations. Now, DISMOD MR 2.1, it is also a software tool developed specifically for the GBD study. It is used for modeling disease burden by calculating incidence, prevalence, and mortality rates across different regions and over time. DISMOD MR 2.1, it is a meta-regression modeling framework that combines data from multiple sources, correcting for biases and handling variations in data reporting. It allows for a comprehensive estimation of health metrics by using information on age, sex, geography, and time, and integrating it into a coherent model. Together, these two methods help improve the accuracy and reliability of the global health estimates by integrating diverse sources of data while accounting for uncertainties and biases in reporting. So these are used for the analysis. Now, moving on to the data analysis, this article has provided a detailed description of all the steps of analysis. And while no mathematical formula was provided. So GBD assembles clinical informatics data, including hospital data, ambulatory, including general practitioner visits and health insurance claims. For each GBD cause disease, non-primary to primary diagnosis ratios and outpatient to inpatient care ratios are extracted from several regions. The log of the ratios is modeled by age and sex using meta-regression Bayesian regularized trimmed, or also known as Bayesian matter regression tool. GBD uses three main modeling strategies, including the cause of death ensemble model, which is CODEM, spatiotemporal Gaussian process regression, which is SGPRT, and DISMOD MR 2.1 to generate estimates of each measure of interest by age, sex, location, and geo. To test whether changes in age-adjusted and drop prevalence, incidence, and DALYs from 1990 to 2019 occurred in certain age groups in particular, or in certain STI groups, we conducted two meta-regression analyses. The first used age group as moderators and 1990 to 2019 changes as outcomes. The second assigned the corresponding STI value to each country and used it as a moderator with again 1990 to 2019 changes in prevalence, incidence, and DALY as outcomes. So the article has clearly showed the candidate model which was used, but no information was provided for the results of evaluation of model performance, like sensitivity analysis. No sensitivity analysis has been given. So detailed steps of analysis were data cleaning and pre-processing, adjustment for data gaps through imputation, spatiotemporal regression to identify patterns over time, meta-regression for stratification by age, model selection, cause of death ensemble model, and no sensitivity analysis has been done. So again, a recap for the questions. So there is all estimates, they are presented with 95% uncertainty intervals in this article, capturing the variability inherent in data synthesis and modeling. So the article describes the method for calculating the uncertainty and estimates in a table. However, there is no source code accessibility provided for in the article. But it shows the tools are used, like DISMOD MR 2.1, they are documented in the IHME repository, allowing replication from there. There is no mention of published estimates in a file format from which data can be efficiently extracted. However, a quantitative measure is being reported for uncertainty of the estimates. Like table 1 in the article includes prevalence, incidence, and DALY estimates for schizophrenia, accompanying by 95% uncertainty intervals. Here's a snip from the article. This shows the prevalence, incidence, and DALYs and YLDs values. And the data in parentheses has 95% uncertainty intervals. This article also interprets results in light of existing evidence. This table shows that the data has been collected from various countries and from various areas having high STI or high middle STI or low in 1990 till 2019. So the GBD 2019 article, it addresses the interpretation of results in light of existing evidence and provides a comparison with previous estimates. Raw prevalence and DALI increased significantly by 65% and 37% respectively between 1990 and 2019, while age standardized prevalence remains stable, suggesting that population growth and aging are driving the rise in raw metrics. So the limitations have been also discussed on page 8, paragraph 2, including biases and underreporting. So the article states, first, GBD applies large data imputation for estimates in countries where sources are limited or absent. This is the first limitation. And an updated systematic review of prevalence estimates of schizophrenia from representative samples is needed. Second limitation is data do not represent any change eventually occurred during the COVID-19 pandemic. Reporting from low-income countries, it should also be improved. Moving on to the conclusion and recommendations. So this article, it meets many criteria in the Gather checklist. It has notable gaps in funding, disclosure, detailed model evaluation, and sensitivity analysis. By addressing these areas, the transparency and reliability of the findings could be further improved. Further recommendation for future studies will be improve the schizophrenia detection in low STI regions and incorporate mortality data for accurate DALI estimates, enhance the model transparency through shared analytic codes. The link of the YouTube channel has been given where the presentation will be uploaded, and thank you.
Thank you very much. Would you please like to tell me, Momena, what are the objectives of this GBD research? Would you please like to narrate the objectives?
So this GBD research basically tried to show the trend of schizophrenia and other mental schizophrenia. Basically, they have used the substance abuse along with it in various regions of the world, starting from 1990 to 2019, and they have seen an increasing trend in this study. So basically, this has provided the burden of the disease globally.
How much the burden has been increased over the time?
Ma'am, I will show you in the results. Ma'am, the raw prevalence has increased by 65%. The DALIs have increased by 37% from 1990 to 2019, while the age standardized prevalence remains the same.
How the DALIs has been calculated in the study?
They have shown that the DALIs, they have, as in shown in the introduction, it has been a sum of the years of life lived with disability, which is YLDs, plus the years lost the years of life lost, which is YLLs.
Okay. How they have calculated the life that has been spent with disability?
By the data provided through the census or household surveys and the registries, like from the hospital data.
Right. How they have done the Bayesian meta regression analysis?
So they have combined three models. First, they have cleaned the data and they have processed by using three models. The cause of death ensemble model, which is CODEM, and number two is spatio sorry 1 minute, spatio temporal regression and Bayesian regression. They have utilized these three.
Would you please like to tell us the details, how they have applied those models? What were the dependent and independent variables?
Okay, ma'am. So the dependent variable was the outcome. That will be the burden of the schizophrenia, and the independent variables were these the age, the sex, the income per capita, the reproductive rate before 25 years of age, the the region they were living into. Also, they had the one second. Yes, this one. So they have included the sex. The differences in sexes were observed. the ages were included from all the years of life, and a peak incidence was seen in that area, 20 to 24 years of age. And they have also included various socioeconomic statuses. They have included people with different educational attainment, fertility rates in women under 25 years of age, and these were also included.
Right, how they have kind of defined the low socioeconomical status, and how they have come up with the socioeconomical status variable in this regression analysis.
Ma'am, they have certified certain values. They have obtained it. I'll show you in the data. Yes, this one. So, a woman. So the low SDI was doing the value is 0.46, which is lower than 0.46, low middle 0.46 to 0.60, middle 0.61 to 0.68, and high middle is 0.69 to 0.80, whereas high more than 0.80.
Dr. Momina, the question is how they have calculated these ranges. For example, if there is a value of zero point 0.8, how they have calculated that value of zero point
Ma'am,
0.8?
they have said that they have included these three parameters for evaluation of socio-demographic indices. Income per capita. They have. I haven't read the complete detail in the article mentioned. They have only given the values, and they have shown that these three variables were used to identify each of the categories of the STI, like income per
You have
capita,
to go
education.
to paper
Sorry.
again because the economical indices they are calculated through certain important parameters. So you have to check those parameters. On that, we have developed these numbers, that zero point 0.8, etc.
Okay,
Would
ma'am.
you please like to tell me about sensitivity analysis? You have mentioned that sensitivity analysis has not been performed. So, what is
Yes.
sensitivity analysis? What we are expecting in this sensitivity analysis?
Ma'am, mostly when a sensitivity analysis is done, it's mostly it is done. It is a method that is used in research to evaluate how changes in input variables or assumptions they affect the output of a model or a research. It helps determine like which inputs they are most influential, and they assess the reliability of the conclusions. Uh, it is I try to read the types of the sensitivity analysis. They had the local and the global types of sensitivity analysis, but this article doesn't provide any information regarding the sensitivity analysis.
So, if there must be a sensitivity analysis, we all agree. And if they want to do it, we have to check first the reliability of the data. So, how can we check the reliability of the data?
Sorry, ma'am, I don't know this. Maybe by
Right.
going to the site they have mentioned, because they have said it that we can check the reliability of data there by going on that site, which has been provided.
Reliability related measures gives the same results. As we know that there are different data sources that have been used. So all the data sources they should be again seen for the reliability that all the sources they are giving the same result. For example, if it is coming from insurance data, or it is coming from the national records, or it is coming from the other sources of primary and secondary data, all the sources should converge to give the same results. So
Okay.
the first important point is that we have to check the Cronbach alpha value for the reliability. The Cronbach alpha value should be more than zero point 0.7 in order to make it reliable. Then we have to go for further sensitivity analysis. Right. So,
Okay.
very good, Dr. Momina. Now you have to do one more thing, that you have to go through the article again and
Yes.
to check how the variables have been defined, especially how the socioeconomical status has been defined, and how the schizophrenia has been defined, and you have to add these two things too. Otherwise, you have done a wonderful job. Thank you. Allah Hafiz.
Thank you, ma'am.